Dr. Arbelo Cruz is an attending addiction psychiatrist at the Connecticut Mental Health Center in New Haven and an assistant professor of psychiatry at Yale School of Medicine. One of her roles at CMHC includes working with the Street Psychiatry Team, a model of mental health and addiction care delivery that takes physicians and other providers to the streets to provide care primarily to those who are experiencing unsheltered homelessness. Dr. Arbelo Cruz received her medical degree from Ponce Health Sciences University School of Medicine in Puerto Rico. She trained in general adult psychiatry at Boston University and the Boston Medical Center, then completed an addiction psychiatry fellowship at Yale. Dr. Arbelo Cruz is the past recipient of the APA Travel Scholarship for Minority Medical Students and the Externship in Addiction Psychiatry Award, Triple AP John Renner Award, and Boston University Medical Center Chairman's Award. She was accepted to the Yale Reach Scholar Program, which is aimed at adequately training physicians to work with minority patients with co-occurring mental health and substance use disorders. Her academic interests include racial inequities in substance use treatment in Latinx communities, stigma of addictive disorders and their treatment, and medical education. So welcome, Dr. Arbelo Cruz.
Thank you so much, Chris, and welcome everyone. I hope that you had your lunch. If not, I hope you have it soon. It's a pleasure to be here. I will be putting up my slides. I just want to start off by sharing a little bit about me. I still kind of new to mainland US. I moved to mainland US, Boston in 2017, and lived there for 4 years, and I have been 2 years in Connecticut. I was lucky that before even going to medical school, I was doing work in the streets in Puerto Rico, in Ponce. I did harm reduction work in the street, and I think that helped me a lot get a first sense of the people who are on shelter. Many of them did not have a substance use disorder, but many others of them did have a substance use disorder. And I think what got me into psychiatry and substance use disorder pretty much was seeing how it was rough for them to get care, and there was not many options. They were limited. And the story that they share with me, something that was kind of ubiquitous, was feeling many closed doors. So with that in my head and a couple of friends that have experience with substance use disorder, all that was cooking in me. And I'm lucky, or I feel blessed, I would say, to be in this field trying to help folks. And I appreciate your time and space of talking about specifically racial and inequities in addiction treatment. For today, what I hope to provide you all is to have a general understanding, a summary of some of the inequities in treatment for substance use disorder in minoritized communities. I want to review with you specific policies that have shaped how addiction is seen today, and policies that have disproportionately affected Black and Brown, Latinx, and Native communities. And lastly, I would like to share some strategies, and I bet you guys can share with me too many, of how to provide equitable treatment services to the folks that we work with. Before we start, I was taking a look at the multiple choice that Christopher was sending out, and I'm happy to see that there are many patient navigators, peer specialists, nurses. So I appreciate that. Thank you for all you do. Most of the work that I do in the street is with non-MDs, and when I work with trainees, how can I put this into words? Something that unfortunately I get from trainees, but it's because of how they have been built and how they have been trained, is like, but Dr. Fabiola, I want to prescribe more. Why do we need to call like housing services, or why do we need to just call probation? Let's just I want to do more prescription. And that's unfortunate because if trainee comes to psychiatry to learn how to prescribe, I think that they will not learn much. We prescribe, but I think most of what we do, to be honest, is case management, meeting people where they are. And at least what I like to have with folks is every time I encounter one person, my hope is that they will talk to me next time I see them. So I just want to share that flavor of the approach that we do here so we can start. By the numbers, I want to start by just having a glimpse of how is the US composition today or most recently. And as we know, the majority of the US population are comprised by white people, close to 60%. And in less number, but still growing a lot, we have Hispanic, Latinx, Black African American, American Indian, and Alaska Natives. And the reason why I'm showing you this is because we have seen the news in the past 10 years, 5 years, 3 years, perhaps yesterday, even today, when it comes to opioid use disorder, there is a disproportionate impact in minoritized communities, Black, American Indian, Alaska Native, Latinx. And there are many hypotheses of why this happened, but it's something that we need to think more. Is it something of the race? Is it something of the unique ethnicity? Or is something else? And my hope today is that by the end of this talk, we learn that this specific population have been made vulnerable to addiction and pretty much health disparities, health inequities. So we have an overdose epidemic, opioid epidemic, and many polysubstance use epidemic. And across all racial groups and ethnic groups, not only minorities community, across all groups, there are big treatment gaps. This particular figure shows numbers or estimate for specialty facility. Specialty facility means mental health services, addiction treatment, rehab, inpatient, does not include self-help approaches like AA or NA. And it doesn't matter because any treatment, including AA, NA, or specialty treatment facilities, there are enormous gap. And you can see in the circle a number 4. So as of recent data of people that have a substance use disorder, when divided by race and ethnicity, less than 4% of people with SUD get specialty treatment. And I just want to point out that even when people go to a specialty treatment, rehab, or an addiction treatment facility, they go there, but doesn't mean that they will get medication. So first, people are not getting into treatment. And if they get into treatment, that doesn't mean that they will get life-saving medications. So the treatment gap is there. What about completion of treatment? Again, same pattern across all racial ethnic groups, white, Black, Hispanic, Native American, even Asians. In terms of alcohol and drug use disorder, the completion rates pretty much are low, not as we want. But I'm showing you this figure because in this particular study, when they adjusted for socioeconomic status, and that's the number that you see in the circle. For example, you can look at Black and Hispanic. When they adjusted, meaning like they took out of the equation employment status or housing instability, what they saw is that treatment completion for minoritized communities like Black or Hispanic, the gap narrowed. And that's important to point out because at least this particular study shows that completion disparities for Black and Latinx were largely explained by differences in socioeconomic status. And we need to remember that marginalized groups are more vulnerable to low socioeconomic status, which is a known risk factor for access and quality of treatment. In addition, in my experience, and I bet you guys have seen this too, when people have a lot of financial stress and need resources, that becomes a competing need for treatment. I have folks that tells me, Doc, I cannot see you. I need to go to work today to get some money. Or Doc, I didn't get the medication. I just need to make sure that I have my kid go to school. I don't have transportation. So social needs, social determinants of health become competing factors. There are gaps in access to treatment. We just saw that there are gaps in completion of treatment. And as how we have heard or seen, there are also gaps in terms of medication for opioid use disorder. And this is just some examples to give you an idea. In the first bullet, in terms of buprenorphine prescriptions, we know that white folks tend to receive more buprenorphine prescriptions compared to Black and Latinx. Similarly, when they look at data in terms of people who have had a recent overdose, they saw that even when controlling for insurance status, even people that were privately insured, Black and Hispanic patients were less likely to obtain follow-up treatment. And the same happened with pregnant patients. And I say pregnant patients because I want to be cognizant that not all pregnant people identify as female. So that's where I use pregnant patients. We have seen that during pregnancy, Black and Hispanic patients with OUD, also pregnancy, have a significantly less likely use of medication like Suboxone or methadone compared to white counterparts. And what are some barriers of treatment? What is going on? A lot of stuff is going on. And just for the sake of summarizing, I want to provide 3 categories of barrier to treatments. The first one is attitude. It can be from the person or from the healthcare providers. I have people that tell me, Doc, and this happens a lot with many Hispanic folks that I work with, I use alcohol or I use opioids, I use cocaine, but I can keep my job. My family is good with me, and they do not perceive a treatment need. There are others that tell me, nah, medications are not helpful, Doc. I don't want to substitute one drug for another because of the stigma. And when I hear that, that's an opportunity to ask for permission to share information. And many times, because I get this a lot when they tell me I'm substituting one substance for another, I just ask them, can I share more information? Usually say yes. And I kind of explain how methadone and buprenorphine, for example, are different from the street drugs. Just saying something on the lines like, well, you know, when I prescribe methadone or buprenorphine, I know the dose that I'm giving you. And when I give you a specific dose, I know I will not be causing the same euphoria that you will get from fentanyl or heroin. In addition, if I give you buprenorphine and you use on top of using buprenorphine or Suboxone, the euphoria that you get is less, and you're protected from overdoses. Lastly, when you use buprenorphine, you have less craving. So being able kind of make a point of how medications are different from the street drugs. Another barrier in terms of attitudes is us. We all have blind spot, and it has happened to me. We can have negative bias towards people with SUD, and unconsciously, there might be other biases against marginalized communities or marginalized communities with other marginalized identities, like unsheltered folks. There are some people that have some conditions that are quite stigmatized, like borderline personality disorder, and all that is plain when we have interaction with folks. After attitudinal barriers, we have social structural barriers, like difficulty finding treatment, being far away from the place they can get treatment, needing to drive 1 hour to get methadone, having primary care or mental health services that do not have addiction services built in, inability to pay treatment. For example, someone that is working has a specific insurance and cannot get Vivitrol because it's quite expensive. Another barrier is lack of social support, competing needs, as I mentioned, stigma, which is a big one, discrimination, fear of getting care and having immigration consequences, or drug-related policies. And I think about pregnant people and females, unfortunately, because many times when these people come to get treatment, they are fearful of what can happen when they get treatment and potentially being punished because of ongoing use. And lastly, there are cultural barriers. There are interesting qualitative studies that mention how people from Black, Latinx communities, for example, might not feel that the service they're getting is tailored to them. And linguistic services are important. Last week, I was working in the street and I had this undocumented male with alcohol use disorder that told me, Doc, I'm new to this area in New Haven. I have pretty bad liver with human cirrhosis, and he was ready for treatment. I called a clinic that I work with a lot, and unfortunately, the people that work there that speak Spanish were not available. And for whatever reason, they wanted to delay the intake until the Spanish-speaking clinician would come to the clinic. And I get their idea, but delaying care is a barrier. And I need to do some advocacy in telling them, so why do you use the interpreter, right? Because at least here in Connecticut, I have seen that Spanish is it's like a second language, right? First being English. And for whatever reason, because of the system that we're built in, they want Spanish-speaking clinicians to give treatment to Spanish-speaking patients. But if it is another language like Arabic or Haitian Creole, for whatever reason, it's more straightforward to use the interpreter. But for Spanish-speaking folks, they want to have the clinician. So that's real. Linguistic barriers are real. So we talk about inequities in treatment, like accessing treatment, completing treatment, not getting medications, and barrier to treatments. Why this happens? And to start, I just want to point out a difference between disparities and inequities. I intentionally use in the title of my presentation, racial and ethnic inequities. And the idea or the rationale behind it is that when we use disparities, which is correct, disparities only refers to differences in health. So it tends to assume that racial and ethnic differences is happening with further explanation, and many people think it's because they have biological differences. In the other hand, when we talk about inequities, it talks about disparities or differences in health that are a result of systemic, avoidable, and unjust policies and practices that create barrier to opportunity. And many scholars like Dr. Ruth Chim and others, myself included, we think that inequities is a more precise term because it gives or alludes to the historical origins of the health differences. And it's important to talk about racism and how racism affects so many levels of our lives. Even if we are not Latinx, even if we're not Black or African American, we are affected by racism. Racism is a system that structures opportunity and assigns value based on phenotype, quote unquote race, or how people look. And it unfairly disadvantages some individuals and community while unfairly advantaging other individuals and communities. And I want to pick a point that racism, not race, is the cause of health inequities and disparities. And how it plays, as we see in the right, is that racism along with gender discrimination or other forces, create power in wealth imbalances in many systems that govern our life: housing policy, educational system, social network, labor market, the criminal justice system. And those power in wealth imbalances in all those systems create unique distribution of resources. So creates unique distribution of job security, food availability, house availability, and that in turns lead to stress psychologically and physically, and that lead to disparities in terms of health. So when we say health inequities, I'm talking about this cycle that is repeated historically and leads to unequal distribution of psychological stress and behavior. And just to provide example how these look nowadays and in the past year, I want to talk about 3 examples of structural racism. And when we talk about structural racism, it refers to all the ways in which society use the interconnected system that we saw before: housing, education, criminal justice system, and all those systems which unfortunately are inequitable, foster racial discrimination, intentionally or unintentionally, which ultimately lead to unequal distribution of resources. Like the first example that we can talk about in terms of structural racism is residential segregation. In 1933, the government established the homeowners Loan Corporation, pretty much to expand home ownership, and it created maps of over 200 US cities using racial composition as part of the assessment. So staff from the homeowner loan corporation, they drew red lines to designate communities of color, hence the term redlining. And that in turn led Black neighborhoods, people of color neighborhood, as poor investment opportunity. That in itself, during that times and year later, even up to today, led to systemic disinvestment in Black neighborhoods infrastructure, services, and employment. And that can translate as not having many clinics in your neighborhood. That can translate as being far away from the bus stop. That can translate to not having many schools nearby. It can translate in many things. To give you an example, back home in Puerto Rico, although it's not per se redlining, in a place that I train called Castañer, we will have people that will come to a very little clinic with strokes, with broken bones, etc. And we didn't have all the resources like ultrasound, X-ray, to be able to take care of the people that came to the clinic. So we needed to put them in the ambulance and take them somewhere else. And this is a very poor community. So by the time that people get to our clinic and then get transferred to somewhere else, a lot of time has passed, which leads to more time opportunity to worsen their health. Just to give an example. In terms of policies for the war on drugs, drug policies from the 1970s up to today, they have disproportionately target people of color for incarceration, despite Latinx and Black having similar prevalence on drug use and white. And this is important because when people have this scarlet letter from the legal system, even if it is because of possession of marijuana, that impacts their opportunity to get jobs, to get housing, to qualify for benefits, for voting, for etc. So once a person is affected, their generation of family members are directly and indirectly affected. And that translates to increased risk for unhealthy behavior, and substance use is one of those unhealthy behavior. Lastly, structural racism can be seen in the healthcare system. There's enough evidence documented in 2003 and even big studies in 2018 that minoritized communities receive fewer procedures and poor quality mental health care than white. So just 3 examples: housing policies, drug policies, and health system that have intentionally or unintentionally affected people of color. And I do want to spend just more time in US drug policy because I think that the way how US drug policy has evolved in the US really shape how we see addictions. The aforementioned inequities that we spoke about, access to treatment, getting medications, completing treatment, exists because of institutionalized stigma and racism throughout drug policy. The first major status of highly punitive law policy was the Harrison Narcotic Tax Act of 1914, which was established to regulate the distribution of coca and opioids. And although it was not intended for this, unfortunately, this law and subsequent jurisprudence were used to prosecute physicians who prescribe opioids for the treatment of addiction, like for withdrawal. So I'm just saying this because that already started to create in the healthcare system, in providers, an idea of we cannot treat addiction because you can get penalized if you treat addiction. Other drug policies like the National Prohibition Act of 1920, the Marijuana Tax Act of 1937, further criminalize substance use, even possession. With the 1970 Comprehensive Drug Abuse Prevention Act and Control Act, pretty much it was a legal basis for the war on drugs, and he established a system for drug scheduling that we still have today. We know that it led to the big incarceration rates of the US that are still live today. And the Harrison Act started to create a plan a seat in healthcare providers in terms of how addiction is different in terms of medical disease. And I think war on drugs and many other drug policies also did a lot of damage, not only to healthcare providers, but the patients, the individuals, family members, of separating addiction as a disease or a condition, seeing it more as a defect, a failure, unfortunately. And I see that still today when I work with my patients, that they tell me, Doc, I feel like a failure to my mom. I feel like a failure to myself. And what I think is unique is that when I have patients with diabetes because of antipsychotics, for example, they don't feel the same guilt. They're not like, I have an A1C of 9. Oh my God, I'm a failure. It's a different kind of emotion that we see in diabetes or unmanaged hypertension that what we see in a managed substance use disorder. And this quote, I think, summarized what I mentioned about mass incarceration because of the war on drugs. It's by Michelle Alexander, the writer of the new Jim Crow book. She says, nothing has contributed more to systemic mass incarceration of people of color in US than the war on drugs. And just to provide some numbers to the left, Black and white individuals use and sell drugs at comparable level, but Black folks are 4 times more likely to be arrested for drug offenses and 2.5 times more likely to be arrested just for drug possession. In that same line, for marijuana use, cannabis use, we also know that Black and white people have kind of similar rates of use, but Black people are almost 4 times as likely to be arrested for cannabis possession. And racism also intersects with other identities, meaning gender and immigration status. To give you an example, there's data that suggests that despite similar rates of substance use between Black and white pregnant patients, Black patients were 10 times more likely to be reported to law enforcement in Florida. And although this is an old study of 1990, this pattern is still today. We know that the child welfare system is overrepresented by Black people, American Indian, Alaska Native, and Latinx folks. So we're seeing how racism and punitive drug policies also intersect with child welfare systems policies. And in the same way, when we look at the immigration system, drug policy also converges with immigration policy. And I'm just putting you this to have an idea. In terms of immigration policy, the way things are written, at this point today, 2013, still having a substance use disorder could be a reason for detention and deportation. To give you an example, many people who have plead guilty in drug courts to not go into the legal system, because of how immigration policies are written, even if you complete a drug court, that plea guilty can be used for deportation. So immigrants, which most of them that are deported are Latinx in the US, but there are many other nationalities of immigrants in the US, the way things are written, it criminalizes substance use disorders. And just to provide a quick example, on 2017, small cannabis possession was the 4th most common cause of deportation for any offense, and the most common cause of deportation for any drug law violation. So again, I just put in this because policies, they have been written, they criminalize substance use and substance use disorders. With all this said, I just want to point out that for us, it's important to know structural determinants of addiction. And this is applicable to any race and ethnicity in the US, but more applicable to Black and Brown people. First of all, the social, cultural, economic, and physical environment do impact the development and risk for addiction and the ability to want to receive treatment. Even people, as I mentioned, that go to a center to get treatment, doesn't mean that they will get medication. They might go and they get offered to stay 2 weeks, for example, for detox or withdrawal management, but they are not started in a medication, in an evidence-based medication. Second, death of despairs. We know that there has been an eroding social cohesion in minoritized communities, and deaths by suicide, for example, not only opioids, are increased in marginalized communities. In terms of healthcare, uninsured rates are worse in communities of color and low-income households. And let me just say this. We know that insurance status alone does not explain inequities in addiction treatment. There has been studies with Latinx folks where we control for insurance status, and we still see the treatment gaps that are bigger compared to whites. So again, insurance status alone does not explain inequities in addiction treatment. I think a level of complexity for Latinx immigrants, specifically for undocumented folks, is that they might not have the same access to clinics or go to all withdrawal management clinics because of the insurance status. So yes, it's a barrier, but that alone does not explain inequities. Fourth, we know that people that are unhoused, they're at higher risk of substance use related death. And unfortunately, Black and Brown people have more housing instabilities. We already touched base on racism, which can be direct discrimination, or all the economic and housing, employment, law enforcement policies that lead to disenfranchisement and disinvestment of community of color. And lastly, trauma. Everything that I mentioned about structural racism, that trauma, that exposure to could be family separation in terms of people that are separated because immigration status, being incarcerated, witnessing overdoses, that impacts the person and put them at risk for addiction. So what can we do? There's no one solution to this. It's a multi-level response, ranging from what we're doing today, education as of reflection, cultural responsive services, diversifying the workforce and workforce development, and addressing policies. And something that I want to share with you all, because we all have blind spot, is we cannot achieve equity if we do not know the inequities. And that's why we need to partner with our patients to understand what's going on with them. That's why we need to partner with Black and Brown communities to understand what's going on with them. Even me, that I'm Puerto Rican and I consider myself Latina, I don't understand fully what happened to Mexican, people from El Salvador, even people from Dominican Republic are my neighbor. So we might have similar difficulties, but it can be different. Again, we cannot achieve equity if we don't understand first the inequities. So how can we provide equitable care? Before I offer some recommendations, I want to provide a general approach to addiction. Us providers, we need to be patient, respectful, curious, and I know it sounds like very simple, but it is not. People with addiction, unfortunately, have received a lot of discrimination, and they will expect initial testing, and it might take time to develop rapport. In street psychiatry, I have folks that I have not been able to provide medication for 1 year, but you know what? In 1.5 years, they want anti-abuse for alcohol use disorder, and that's progress. Being with them, supporting them, that's progress. Second, we need to anticipate early struggles. Not everyone wants to stop using. Some people want to reduce use. And I have seen sometimes friction between what I want or the provider wants versus what the patient wants. There are competing needs, as I mentioned, and people respond to stress. As I mentioned, marginalized communities have a lot of stress from trauma, financial instability. Not all of them, but many of them have, and that can impact how they see treatment. They might not be ready treatment today. They might be ready for treatment 2 months from now. I had one experience where I was called a Suboxone dealer. About some months ago, I had a patient that wanted treatment, and in his history, he came to clinic 1 year ago, and he was starting Suboxone, but was missing a lot of appointments. It was hard to keep this person engaged, and ultimately, it was decided not to continue Suboxone. Now he returns 2 months later, and he said that he's willing to start Suboxone, but the previous provider had a negative interaction and had like a negative feeling and did not want to provide Suboxone because the person thought that the same pattern that happened 1 year ago was going to happen now. And I'm not saying that was not going to happen, but people change. I changed from yesterday to today. People with addiction also change. And today might be a new opportunity. So we need to keep an open mind. What happened 1 year ago doesn't mean what happened today. We need to keep that in mind. And lastly, this is the most important point for me. Patient needs to be reassured that they are welcome back. Just being there for them, for the worst, is crucial. Medication might not fix the problem today, but you being with them might help them keep coming to the clinic, which can help them perhaps reducing use or starting medication 2 months from now, 5 months from now. If someone has a recurrence, it's not about the guilt or punishing. It's about learning. Like, what happened? What can we do differently? Can we intensify treatment? We cannot add to the guilt. Addiction is not easy. So we need to be with our patients. And now I'm going to show you a video of someone that gave permission to share this video, someone that is on house and shares his experience with addiction.
Well, yeah, matter of fact, I did get treatment, but one of the things about the treatment, I don't feel I had support. I mean, people think that you can just stop, and you can't just stop. You have to have some support, especially one of the things I needed my wife's support. But, you know, like she might have came to a meeting one time or 2 times and say, you can stop this, but you can't stop it. You have to keep supporting them to a certain extent, to a point where it's just like they will say to you, man, why do you keep helping me and I keep messing up? And when you can get there, that's hard to do. I know it's gonna cost you and it's hard to do, but that's the way you kind of stop. And when you know you're gonna stop is when you know you don't want anybody to feel like you felt. But you hadn't hit your bottom until you don't want your friends, family, anybody feel like you felt. It take you to where it takes you.
That's JR. And I have spoken a lot. I just want to make a stop here to hear folks or read folks in the chat. I just want to throw a question. What is hard about being of support to our patients with addiction, with active use? What are some of the things that come up to you all? I can share myself, but I also want to hear what are some of the hardest aspects of just being there, being of support to our folks? Because it's not easy at times, at least for me. And you can drop words in the chat or unmute yourself. Thank you, BJ. I don't know who's BJ. Thank you. Getting them to even consider treatment is difficult at best. Thank you. Constant worry if they're alive when they don't show up to appointments. I have been there as well, Katrina. Liz, thank you. Difficult watching individuals make decisions that are hurting them. Yes. I was walking to eat food last week and I saw someone that I have not saw in 1 month, and I was scared as well because it's someone that I usually see in an encampment. And she just told me, she was happy to see me, and she told me that she gave her cell phone as collateral for methadone, which she did not. A friend of her that she was staying in a tent, unfortunately gave her cell phone as collateral for methadone. And she started crying, saying, I'm stupid, I'm stupid. And that was hard for me to hear because I don't think she's stupid, but you can definitely, I felt how she felt hurt. And I don't think she was hurting herself. The addiction had control over her. So I'm just saying this because we might think they're not hurt, but they're hurt as well. Megan, stigma of being judged by the healthcare provider. Thank you, Christopher. I think sometimes we, even though we really want to meet where people are, we may have to combat our own desire to fix the situation or relieve some of our own discomfort for the gravity and difficulty of the situation. I have been there as well, like wanting to do something. What do you do when you cannot offer much? Please know that being there and just saying, I am here is enough. One can feel uneasy, but it's enough. Daniel Woods, trying to get them understand the importance of it. Yep. Katrina Nichols, feeling judged by other healthcare workers, says, I didn't convince or make the patients to change. Yes, we get a lot of pressure from others that says, oh, why you didn't do this? Or what happens to me, and I bet to you as well, is unrealistic expectation. To give you an example, I work in an encampment in New Haven where mainly Latinx folk, undocumented people live. And because, unfortunately, in the train tracks that is nearby, someone passed away 5 months ago, they want to shut down that encampment. And we have been working with the Department of Transportation since May to develop a plan. How can we target case management to at least have creative ways of offering shelter space or housing people? Because not everyone wants to go to a shelter. Some of the things that I learned from my patients are the shelters have strict rules. You need to get there at 5 p.m. You need to get out of there early as well. And many of them need to use fentanyl or alcohol at 11, 2, 4, 5 a.m. to not have withdrawal. And unfortunately, with city officials, they have a lot of pressure of us finding them house ASAP. Or they just open it 30 shelter beds for folks to go there, but not all of them want to go to shelter. So what do you do? And it is hard, but what I learned is 2 things. You might try to advocate for them. Things might not go as the way you guys want, but when this happens again, perhaps of the advocacy of today, the second time, the 5th time, the 15th time, the 47th time, there will be improvement, and just continue to planting the seed. Second, because I think something that we need to do as addiction provider is celebrate small wins, and we need to keep hope. Maybe there are 40 people that you're working, but if you're able to help 2, it might not sound enough, but you are moving up. Like we said in encampment, we're able to get voucher for housing, which does not mean housing, means just having a voucher for 5 folks out of 12. That's progress. That's progress. We don't know if they're going to get housed, but this community, this monolingual Spanish-speaking community, they haven't received a voucher. Five folks from that community have not received a voucher in the last 3 years. So at least we achieved something. They were able to connect with case management. They trust us. Even if they are unfairly displaced, they trust us. So for the sake of time, I will continue, but thank you for putting your words. So support for the people that we work with is crucial. What about in terms of treatment? How can we view treatment so it can be equitable? First, it needs to be ready, available. And you might not be able to change this, but you can advocate for this. What readily available means? First, minimal demands on the patient. For example, I work in a clinic where if someone was on benzodiazepine and they were not willing to down taper, like stat, they will not be able to continue in the clinic. And that might be unfair. It might be that you need an 8 months taper. I'm not saying that we will not change it, but that's very rigid. Or having people to comply with 3 specific appointments and continue. And if you miss 3 appointments, you're discharged. Second, we need to incorporate harm reduction strategies. Again, I see many people that just want to reduce alcohol use, and the clinic might not have that as a goal. But trust me, going down from 4 bottles of wines to 1 is wicked hard. It's not easy. And if we achieve that, that's a move to progress. And lastly, going to the community. I'm gonna speak a little bit about that later, but many of the folks that I work with, and I bet you guys work with, do not get to the clinic. So what can we do to get to them? Second, treatment needs to attend the multiple needs of our folks. And I'm talking about the social aspect, being able to have housing, food, education, or job opportunities. They might not get it right away, but if in 1 year you're able to get them have an ID, birth certificate, be connected with food stamp, be connected with insurance, that's moving to progress. And just making a stop here, I work a lot with housing management, and I know it's difficult to work in terms of housing with people that are actively using, and it's just even hard to find them in the street. I recently was told the following: Dr. Fabiola, it's hard to work today on getting a house. I don't think they might be ready to get a house because it will be like giving keys to a baby. And I sat down with that thought, and I actually went to a colleague of mine that happens to be someone who currently uses, but also is a peer specialist. And he told me the following: oh, you know, Fabiola, thinking about it, although sounds hard, I kind of agree with it, but hear me out. I have been never given the opportunity in 10 years of having a house. It has been hard. So if I get a house, I don't know how to have a house. I don't know how to go about it. I need someone to walk with me and tell me how to get things done. So I'm just saying this because stigma is there. I am not immune to it, but I'm just sharing example of manifestation of things that I experienced in my work. Treatment should be of adequate duration. Something that I do in my work is that when I'm talking about Vivitrol or methadone or Suboxone or antabuse, I ask the patient, for how long do you think you need to be in treatment? And they usually tell me, well, I don't know, 2 months, 3 months. And I'm like, no, as long as you need to. And in terms of studies, we know that people that have been less than 3 months, they tend to do less well. Specifically for methadone, we have seen better results in people that at least have been 12 months, a year. So if you get that question, you can tell the patient, as long as you need to, at the minimum 1 year. And lastly, equitable addiction treatment includes effective medications, because medication do work, and culturally informed counselings and therapies. And I know not everyone wants medication. That's okay. but the cultural informed counseling and therapies can be implemented. And I cannot imagine my work without addressing social needs. And I know it can be hard. In one appointment, in those 30 minutes or 10 minutes, because some people don't tolerate 30 minutes, you don't get things all done. You try, but at least we need to ask these questions, because not knowing them will lead to ongoing negative health outcomes. Even for phone, maybe you have a lot of experience with it. I might have, let's say, Louis. I have Louis cell phone 1, Louis cell phone 2, Louis cell phone 3, Louis cell phone 4, because there's folks that change cell phones a lot, right? Being mindful of asking people, hey, are you interested in shelter or not? Because if they are, it's not that you have to have a solution, but at least you can partner with communities. If I don't partner with communities, I will be burnt out a lot. So in the work that I do, one thing that I'm trying to do and continue to do with my colleagues is getting to know New Haven, Middletown, where we are, and seeing what's out there. Where can we send people that do not have insurance? Where can we send people that provide services in Spanish, or at least some services? Where can we send people to have someone that will help them in 7 days to figure out what's happening with food stamp? That is important. And meeting people where they at. For a long time, healthcare system have opened the door and wait people to come in. That's how I do it. When I go to my doctor, I go somewhere. I don't think no one goes to me, only my mom and family members, right? Significant others. And for our patients, it's the same. They need to go somewhere, but we're missing a lot. So what can we do to meet them where they at? I'm not saying that they should not go to the clinic, because in my work, I don't want to take people out of the clinic to the street. I want to take people from the street to the clinic. But we need to go out to the field more. We need to think about creative ways to engage people. Like, I work as a research physician for the Imani Breakthrough Project, which is a study and intervention, a faith-based intervention for Black and Latinx folks. And for a couple of years, the principal investigators have paired up with community leaders, specifically reverends, people from specific churches. And the treatment for addiction is in the church, a place that is quite well known, familiar to Black and brown people. And I have seen in my work at one specific church in Hartford, mainly for Latinx folks, that people come not to see Dr. Fabiola, to go to church and to the group. And that's nice to see. I don't take it personal they wanted to see me, although at times I do, but it's nice to see that they want to go. Also, in terms of helping our minoritized folks, we need to diversify the field. But not only that, we can train ourselves to be better able to treat the minoritized folks and know what is cultural informed interventions. And this is just 2 examples of how training the workforce look like. On the left is the REACH program, which is a 1-year experience for trainees interested in addiction. It can be medical student, it can be nurse practitioners, PA, it can be residents from whatever specialty, it can be fellows. And in that 1 year, they get quite a lot of training of culturally informed interventions, and they get a lot of education about the structural forces, like structural racism in healthcare, in policies that lead to unequal distribution of resources and treatment. And I say this because I was part of this, and all this knowledge that I got from this, and I continue to have, it was not taught to me in college. It was not taught to me in medical school. It was not taught to me in psychiatric residency. It was not taught to me in addiction fellowship. So I was lucky that the experience that I have from working in the streets in Puerto Rico and experiences like this help me know more, that definitely helped me understand more, have less stigma, and empathize even more. To the right, just want to talk briefly about the Hispanic Clinic of the Connecticut Mental Health Center. It's a clinic that got funding, because funding is important, from Yale University and the state of Connecticut. And because of having those supports in place, it got funding to open a clinic mainly for monolingual Hispanic Latinx folk. And everyone that works there, from the front desk staff to the psychologist, social worker, MDs, speak Spanish. It also helps train medical students, fellows, and does a lot of research in terms of how can we understand and treat better Latinx communities. In terms of cultural responsive intervention, I just want to provide a brief description of how it looked like. There are many definitions of what is cultural responsive intervention. It can be as speaking the language, or having people from a specific group, or changing evidence-based therapies to meet the need of particular groups, or designing a whole clinic, right? So there are many aspects of what is a culturally responsive intervention. And just for you to have a common understanding, when we talk about culturally responsive intervention, we can have like three main categories. One, incorporating cultural values in the clinic, and that can mean the language, having people from specific backgrounds. Second, culturally adapting evidence-based intervention. For example, something that comes to mind, there's a therapy that called CBT for CBT. So it's a therapy online module, right? So folks from the Hispanic clinic actually work on adapting CBT for CBT for Latinx folks. And they use telenovelas. Even the character that is in the therapy is a grandmother that says a lot of dichos or saying to the folks. And pretty much is taking something that has evidence base and putting it to a specific group. And it's important to know that if you design something for a specific Latinx group, doesn't mean that it will work for many other groups. So culturally responsive intervention can look different depending on the racial and ethnic group involved. They can be given a different setting with different goals. So not one culturally informed intervention works for all folks. And lastly, of the three approaches for culturally responsive intervention is implementing strategies, like what I said about the Imani Breakthrough Project. This slide talks about two specific examples of successful models designed by the people for the people. I will start from bottom to up because I already talked about Imani. So Dr. Bellamy and Jordan founded the Imani Breakthrough Project. Pretty much, they wanted to target Black and Latinx folks and getting into treatment because we know that they have decreased treatment initiation, engagement, and completion. And they successfully engaged hundreds of people in groups, in a church, in a place that is a safer path. And they trained people to give the therapies. Up, we have the medications for opioid disorder for American Indian and Alaska Native opioid disorder. And pretty much what Dr. Benners and others did was sitting down with the people and talking about treatment and what they want. And what they saw just by doing that was that there was a mismatch between the concept of free medicine healing and what they were offering, the standardized MOUD. And they were able to integrate the cultural abuse to clinically implement the medication for opioid disorder for a particular group, American Indian, Alaska Native. Lastly, in terms of advocacy and policy, I am focusing in drug policy, but this can go beyond. We need to undo the damages of criminalization of drug use. For example, we can decriminalize simple drug possession. I have folks that just because they have in their pocket 3 pills of benzodiazepine, they might have a legal issue just because having 3 pills of benzodiazepine. I have many folks that 15 years ago, because of simple possession of marijuana, they had legal charges and they got pretty much affected for employment, housing opportunities. And to be honest, it's quite hard to see now how many other groups lucratize from cannabis businesses, knowing that for long, specific groups suffer a lot. So decriminalizing drug possession is one way that we can advocate and change policy. Second, ending policy that permanently exclude people with drug arrest or conviction from key rights and opportunities like loans, employment, financial aid, child custody, public housing. And lastly, as another example, adopting pre-plea diversion programs that allow people with low drug offenses to successfully participate in treatment without having to have a guilty plea. As I mentioned, there is data in terms of Latinx folks that many of them, you can think about Washington Heights in New York, going to drug court, plead guilty, and then, although the criminal justice system don't see that as a specific conviction, when they are involved in the immigration court, is not taken in the same way, and they can have huge impacts because of it. So to some, I know I share a lot, there's a lot to say, but if I want to remind people of 2 specific aspects, is one, we cannot achieve equity if we do not understand the inequities in the first place. So it's vital for us to continue learning and recognize and understand the structure and policies that contribute to inequities in substance use disorder in people of color. Second, tackling this takes a lot of hands and multiple brains and multi-level response. Doing things like this, educational events, self-reflection, culture responsive services, workforce development, diversification of workforce, and addressing policies are key features of addressing health inequities in substance use treatment.
This question may be better served for next week because it could be a long question. So please feel free to tell me, we could punt it, but maybe while others are thinking of questions, I am just curious more about the development, like how it came together to have a program development, or like the funding sources involved, the people involved, or how to kind of, when you're someone that's interested in trying to start a program that is more going to the community. So whether that be, a street program, a mobile program, things like that, what have you found to be the key people, places, funding sources, those types of things that are needed to be successful to try to do that effectively?
Thank you. The first thought that comes to my mind, and I'm still learning today, is to not reinvent the wheel. There are many people that are doing good work out there, and it's like important to know which people and organizations to be connected with. Like, for example, street psychiatry, Dr. Law founded, I work with her. She had built in from the Department of Mental Health and Addiction of Connecticut, because we are state funded, so we already have a connection with them. And she trained at Yale University, so she had that and knew many people in the field that were already working with unhoused individual. So the collaboration was not only with our institution that was going to fund it, but the case manager services of New Haven, the street medicine team, not street psychiatry team, that was already doing work years prior. Speaking with leaders from the Street Medicine Institute, which is a larger world organization, because there were people already doing work like this in Philadelphia, California. So asking the questions to specific people and getting help. I think when we try to reinvent the wheel, and I have been there, one feels overwhelmed, right? And it's okay to just try your effort and try to have something yourself, but asking others and asking the pitfalls of others. To give you an example, in the last month, with the housing crisis and shelter folks that we have behind New Haven, for the most part, we can do disability verifications for people that have a disabling mental health and addiction condition. And that just prioritize them in the big list of people that want a voucher or being housed. We're looking at how can we do the same for chronic disabling medical condition. Because there are a lot of folks that, I don't know, they have a stroke, wheelchair bound, that live in the street, and we can prioritize them as well in the list. They can be prioritized in other ways, but we want to prioritize them in the list the same way that we do for addiction and mental health. And we have ideas how to do it, but we have never done it. So I remember going to the National Healthcare for the Homeless Council annual meeting in May and seeing a conference about how to house the medical frail, because some people in Alameda, California were already doing it. So I just reached out to them, they responded, and we're looking to do a meeting to learn from them, just to have a better idea, because we will always learn and we will always improve. But hearing others is important. And I just will say one last thing about implementation. Good intention is not enough. I repeat, good intention is not enough. To give you an example, when I was working in Boston, there's a program called Project Respect, mainly working with pregnant people with OUD. We have good intentions of targeting the people, and Boston Medical Center, 70% of the patients, 70% are people of color. And when we look at the patient population of Project Respect, closer to 90% were white. So it's like, what's going on? So good intention is not enough, but because data was looked, we were able to see what was going on. And then they developed a new team that was targeting to people of color because they saw the discrepancy. The same happened in street psychiatry. Although I was not involved with that data lookup, like 3 years ago, they were looking at the people that were involved with us, and the majority were white. And it's like, man, good intention is not enough. Doesn't mean that we're doing something intentionally wrong. I have seen this in many other studies in people that are looking to provide treatment in ED. It's just that we need to be intentional of how to implement things and for everyone to get in.